You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about flow reserve measurements. Nowadays, there are a plethora of flow reserve measurements to choose from in a cath lab. The mainstay is FFR, or fractional flow reserve, which is a hyperemic pressure ratio available from all companies. There are 5 non-hyperemic wire-derived pressure ratios. Whole cycle ratios are resting PDPA, which is available from all companies, RFR, or resting full cycle ratio from Abbott. The diastolic or subdiastolic ratios are IFR, or instantaneous wave-free ratio from Philips, DFR, or diastolic hyperemia-free ratio from Boston Scientific, DPR, or diastolic pressure ratio from UpSense and ASYST. There are 3 angiography-derived FFRs that are wire-free: QFR, or quantitative flow ratio from MEDIS and Pulse Medical, FFR angio from CathWorks, and VFFR, or vessel fractional flow reserve from Pi Medical. Outside of the cath lab, there are 4 CT-derived FFRs: FFR-CT from HeartFlow, CFFR from Siemens, CT-FFR from Canon, and CT-QFR from Pulse Medical. These indices differ by whether they are used during or whether they are measured during the whole cardiac cycle or only during diastole, whether they use a hyperemic agent such as adenosine or do not induce hyperemia, and what point during diastole is used. In this episode, we will focus on the wire-based indices: FFR, PDPA, RFR, and DPR. We'll start with the resting PDPA, which should be more than 0.92 normally. The simplest translesional pressure measurement is the resting PD over PA, which is the ratio of the intracoronary wire-based pressure measurement distal to a stenosis, PD, to a pressure measurement proximal to the stenosis, usually aortic pressure from the guide catheter, PA. Resting PD/PA has been tested in one RCT, the LIPSAS strategy, and one retrospective study. Resting PDPA is not commonly performed anymore due to the availability of RFR, IFR, and FFR. To recap, for resting PDPA, there is no need to give intracoronary medication. Get the mean PDPA over a whole cardiac cycle averaged over 3 beats. Next, FFR is fractional flow reserve, which should be more than 0.80 normally. FFR is an index of the driving pressure for microcirculatory flow distal to the stenosis, distal coronary pressure minus coronary venous pressure, relative to the coronary driving pressure available in the absence of a stenosis, so mean aortic pressure minus coronary venous pressure. FFR is based on the principle that distal coronary pressure measured during vasodilation is directly proportional to the maximum vasodilated perfusion. To induce a hyperemic state, adenosine is most commonly given, although less commonly, papaverine, nitroprusside, or regadenoson could be given. In terms of route of administration, intracoronary adenosine is preferred if there is focal disease or a history of severe bronchospasm, whereas IV adenosine can be given if there is aortoosteal disease, serial lesions, or diffuse disease. FFR has been tested in the following RCTs: DEFER, FAME, DYNAMI 3 Pre-Multi, and COMPARE Acute. To recap, for FFR, you give intracoronary adenosine. Get the mean PDPA over the whole cardiac cycle during hyperemia, average over 3 beats. Next, CFFR is contrast fractional flow reserve, which should be more than 0.83 normally. Because adenosine may not be accessible to all healthcare settings due to expense and availability, and since it can cause discomfort to the patient, contrast FFR was introduced, taking advantage of the fact that contrast is known to introduce some degree of hyperemia. PDPA has lower diagnostic accuracy in the left main and proximal LAD. To recap, you give contrast instead of intracoronary adenosine. Get the lowest mean PDPA over the whole cardiac cycle. Next, IFR is instantaneous wave-free ratio, which should be more than 0.89. To avoid the need to administer adenosine and associated patient discomfort, non-hyperemic pressure ratios or NHPRs were introduced, starting with instantaneous wave-free ratio. In 2012, Sen and colleagues discovered that there is a period in diastole during which the reflected pressure waves from the aorta and distal microcirculatory bed are quiescent, which is now referred to as the wave-free period. The wave-free period has fixed resistance. IFR is measured during the wave-free period, which begins at 25% of the way into diastole, where the beginning of diastole is defined as the upslope of the dichrotic notch and ends 5 milliseconds before the end of diastole. IFR has superior signal-to-noise ratio than resting PDPA. IFR has been tested in 2 RCTs, IFR Sweetheart and Defined Flare, and 1 non-randomized trial, Syntax 2. To recap, for IFR, there is no need to give intracoronary medication. Get the mean PDPA during the wave-free period, which begins at 25% into diastole, averaged over 5 beats. Next, the DFR is the diastolic pressure ratio, which should be more than 0.89. Since the introduction of IFR, several other NHPRs have been introduced. Van Beer et al.'s landmark paper showed that several new indices, the diastolic pressure ratio, which is PDPA during whole diastole, DPR 2575, which is PDPA at 25% into diastole going to 75% into diastole, DPR mid, which is PDPA at the midpoint of diastole, and several IFR-like indices involving shortening the wave-free period by 50 and 100 milliseconds, IFR negative 50 milliseconds, and IFR negative 100 milliseconds, had extremely high correlation compared to regular IFR. The diastolic pressure ratio, or DPR, measures average PDPA during the entire diastole from absence or at the midpoint of the peak to peak of the filtered PDPA from assist. There is no need to give intracoronary medication for DPR. Once again, for DPR, you get the mean PDPA at the peak to peak midpoint assist or the mean PDPA during the entire diastole absence, average over 5 beats. Next, DFR is the diastolic hyperemia-free ratio, which should be more than 0.89. The diastolic hyperemia-free ratio, or DFR, is the measurement of PDPA during the period starting from when PA falls below average PA and ending when the downslope of PA stops. The key point to remember is that DFR, DPR, and RFR are all highly correlated with each other and with IFR, and all share the same cutoff value of 0.89. Normal should be more than 0.89 and abnormal is 0.89 or less. There's no need to give intracoronary medication for DFR. Once again, for DFR, you get the mean PDPA when the PA drops below mean PA and the downsloping PA, average over 5 beats. Lastly, RFR is the resting full cycle ratio, which also should be more than 0.89 normally. RFR takes the lowest value of PDPA after a noise filter is applied. No need to give intracoronary medication. You get the lowest filtered PDPA during the whole cardiac cycle, average over 5 beats. We will briefly touch upon the non-wire-based QFR or quantitative flow reserve, which should be more than 0.80. Quantitative flow reserve is an index obtained by applying flow equations to 3D reconstructions of the coronary tree via combining 2 angiographic projections that are at least 25% apart, ideally orthogonal. Coronary flow is indirectly derived from the TIMI frame count. The estimated contrast flow velocity is determined by assessing when contrast enters and leaves each segment of the vessel. This analysis can be applied to angiographic images either online or offline. The software is able to provide details about pressure drop in each segment of the vessel, mimicking a pressure wire pullback. Now, back to the wire-based indices. When should you use a hyperemic versus a non-hyperemic index? Consider using a hyperemic index such as FFR when you have left main disease, systolic dysfunction, post-PCI side branch interrogation, or post-PCI assessment. Consider using a non-hyperemic index such as IFR, DFR, DPR, RFR when you have tandem lesions, diffuse lesions, LAD disease, In multivessel disease or diabetes, hyperemic and non-hyperemic indices perform similarly. One last summary of all the indices and their cutoffs. Abnormal FFR is 0.80 or lower. Abnormal IFR, DFR, DPR, RFR is 0.89 or lower. Abnormal PDPA is 0.92 or lower. Above the cutoff, that's normal and you can defer PCI. At or below the cutoff, you should consider PCI for ischemia. That wraps up this episode on different flow reserve measurements.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.